we require some indicators to understand what is the burden of disease and whether there is any new transmission, whether transmission of the disease is occurring or not. Whether transmission of the disease is occurring or not. Okay. To have an understanding of the burden of disease and to understand whether transmission of the disease is occurring or not, and to understand what is the type of malaria transmission that is occurring. Okay. For these purposes, mostly we have our these two indicators, which is the annual parasite incidence and the annual falciparum incidence. So as you can see, annual parasite incidence, it is the total number of confirmed cases of malaria in a year divided by the total population under surveillance. Okay. Now, how to make confirmed cases of malaria in a year? How to label a case as a confirmed case of malaria? How to do that? What is the way of confirming a case of malaria in our country? So the way to do this annual parasite incidence, how to do? So we have to do the slide examination under the microscope. Okay. So confirmed cases by slide examination. Okay. So you do thick smear, thin smear, you look under the microscope, you look for the malarial life stages of the plasmodium that you assess. Okay. Now, microscopy is not always possible in some difficult to reach areas. So in the Northeast, even a diagnosis by the rapid diagnostic kits. Okay. The diagnosis by the rapid diagnostic kits in the Northeast is sufficient to label a case as confirmed case. Okay. In the rest of the country, cases, they should be confirmed by doing slide examination. In the Northeast only, you can do rapid diagnostic kits. Okay. Areas which have a API of greater than 2 are labeled as high risk areas. Okay. Areas which will have a API of more than 2 are labeled as high risk areas for malaria transmission. Okay. What is AFI? AFI is the same thing, just instead of all confirmed cases of malaria, we look at the Plasmodium falciparum cases specifically. Okay. Why is this necessary? This is necessary to look at the pattern of transmission that is occurring. Okay. So many places they will be endemic to vivax, but due to some migration and other things there, the things will gradually change to falciparum. Like Kolkata, over the last, if you look at the problem in Calcutta, you will see that over the last 2-3 years, the rate of falciparum malaria is increasing gradually. Okay. So that indicates some changes in the vector behavior, some changes in the disease patterns, and based on the type of disease that is becoming more, those drugs also need to be supplied, and those diagnostic kits, those drugs, those measures of controlling the disease have to be present with the program. Okay. So the program needs to understand, okay, not only how much of the disease burden is there, but also how much of that is falciparum and how much of that is 5x, because the treatment of the two and the challenges of reducing the burden of the two diseases are different. So these are the initial programmatic indicators that look at, okay, what is the programmatic effectiveness? Okay, that when this program is running, whether this program is able to reduce this API or not. Okay. Next, we look at annual blood examination rate. So annual blood examination rate is a very, very important indicator. What is its importance? Can anyone say what is its importance? Annual blood examination rate. Why do we need this indicator? That is looking at the number of slides examined in a year divided by total number of population under surveillance.
For the operational efficiency of the program.
For the operational efficiency. So why is it giving us the operational efficiency?
It indicates the number of slides being examined under the active and the passive surveillance that we get.
Exactly. So see, by simple logic, the easiest way to reduce API, the easiest way to report low API is to not test. You don't test people, people don't get tested, results don't come positive, and your API is low. Okay. So the program has to ensure that, okay, if people are reporting a reduced API, then it is due to actually a low transmission and not just due to us closing our eyes. Okay. So API will become only reliable if the ABER is above a particular threshold. Okay. And the objective is to increase and keep this ABER at a level of at least 10%. Okay. This is done with the estimate that, around the year, at least 10% of the population will suffer from fever at least once. Okay, due to some communicable disease or anything. Okay, so with that notion in mind, if people are having fever and we are doing this active surveillance and passive surveillance, then at least 10% of the population under surveillance should have their slides examined at least once in the year. Okay, so that is known as the annual blood examination rate. Monthly blood examination rate can also be calculated. It is calculated not to look at programmatic efficiency, but to just look at the seasonal patterns. Okay, from the monthly blood examination rate, you can have an idea about the seasonal transmission of malaria. Because even in terms of low transmission, you need to have an adequate blood examination. A bare minimum of blood examination needs to be there to ensure that those are really, like, you are really aware as to what are the transmission dynamics during those low transmission sessions as well. Okay. Next, moving on, we have something else known as slide positivity rate or slide falciparum rate. These are indicators for outbreaks, because as you can understand plain and simply, that with, if the disease transmission is low, then with, so what is this slide positivity rate looking at? It is looking at the numerator of the two previous indicators. It is looking at the number of slides positive for the malarial parasite divided by the total number of slides examined. So assuming that my ABER is sufficient, if my ABER is sufficient and I'm examining sufficient number of slides, then if the disease is low, the transmission of the disease is low, then the number of slides positive will be low and I will have a low slide positivity rate. But if I am having a high slide positivity rate, that will mean that okay, outbreak is probably happening, because I am not testing all slides. Whatever slides I am testing, most of them are coming positive. Okay. Many a times, with passive surveillance also, if the active surveillance is not happening properly, you can have a high slide positivity rate, because you're only testing those slides of people who are coming to you with the symptom cluster to get treated for malaria. So there the proportion of positive slides will be higher. Okay. So slide positivity rate, it has to be interpreted in the situation of where you are having a sufficient ABER and where your active surveillance is like is functioning properly. Okay. And that is only when you can reliably make interpretations out of slide positivity rate. Okay, so slide positivity rate, it is an indicator for outbreaks. It is very, very important to understand that it is an indicator for outbreaks. So during the monsoon seasons or high transmission seasons, the slide positivity rate becomes important. Just like API and AFI, with slide positivity rate, you also have a slide falciparum rate or a plasmodium falciparum percentage. Okay, so this will again tell you that the pattern of the disease that is evolving, which disease is transmitting more, which disease is transmitting less. Next, we look at two more things which are known as infant parasite rate and child spleen rate. Okay. So you see, with malaria, there is this problem of relapse and recrudescence. Okay, so a person comes to you with malaria, it is very difficult to always tell whether this is a new case as a result of indigenous transmission, or this is a case which is a relapse or a recrudescence. Okay. So suppose you have a low API in a particular state and you want to know that whether whatever new cases we are getting, whether those are relapse and recrudescence, or are those new cases actually out of new transmission. Okay. And the best way to ascertain that is to look at the infant parasite rate, because the infants, they are the new people in the population. They have been added to the population in the last 1 year. So if you are able to show that the infants in the are having any parasite, or the infants are having uh, the malarial parasites in their blood, then you'll definitely be able to say that, see, the infants are having this parasite. That means that indigenous transmission or local transmission has been happening in the last 1 year. Okay. So these are indicators. Again, child spleen rate, it is a epidemiological measure of malaria prevalence in the recent past. So once a state is or a country is going towards malaria elimination and it is talking of malaria eradication, the infant parasite rate and the child spleen rate, they become vital indicators for the country to be looking at. Okay, so just to recap, the indicators that we looked at are parasite incidence, annual falciparum incidence, annual blood examination rate, monthly blood examination rate, slight positivity, slight falciparum rate, infant parasite rate, and child spleen rate. Any questions you have so far?
Can you explain why the child's spleen rate is important?
If you're
Because
having
I
any
had some
question,
network issues.
you had.
Sir, the child's spleen rate, can you explain it again? I had some network issues.
Okay, so the child spleen rate, see, suppose you are trying to find out what is the burden of the burden of malaria in the community in the recent past. Okay, suppose you are a country which has achieved elimination and is talking about eradication. Okay, so then you want to look at whether there is any chronic transmission or reinfections of malaria that are going on in the community. Okay, so as you know, with repeated infections of malaria or with infections of malaria in children, there is the year of having splenomegaly. Okay, and splenomegaly is something for which you do not need to do any invasive test. You need not take blood, you need not do anything. You can just palpate for the spleen, and if splenomegaly is there, then you can say that, okay, this is probably due to malaria. Okay, so it is a very good epidemiological measure where you're doing a non-invasive, cheap, easy to administer test with which you can find a way of gauging the local transmission, whether there is any local transmission that is happening in the recent past.
Okay,
Okay,
sir.
so infant parasite rate and child spleen rate are both indicators that become vital to countries when they are trying to establish that they're moving on from elimination to eradication at that. Okay. In order to establish that, okay, whatever new cases we are getting, we are not getting them in children and in infants. So probably those new cases are as a result of relapse and recrudescence and not due to indigenous transmission. Okay. So So going ahead, let us now talk about, so once we know about the indicators, so whenever there will be high PI or the burden of the disease is high, see, mostly the surveillance we are going to do of these indicators. Surveillance we are also going to do about the vectors. So various vector things we will also look, and we are doing active case management. Other than that, what we had left and we will be discussing now is the integrated vector management. Okay, so as we want to discuss the integrated vector management, what we need to know is how did the vector control techniques evolve in our system. Okay.